Our next panel is on sonodynamic therapy. This panel is going to be moderated by Dr. Prada. We have a couple of people joining us in person and a couple virtually as well. So this is the last panel before lunch. And I will also plug, please take a little bit of time to look at the platform. As was mentioned by Dr. Chen, it's a great resource, and it's like a whole additional meeting in and of itself of just scientific presentations. All right, Dr. Prada.
Good morning, everyone. I'm very pleased to moderate this panel on sonodynamic therapy. I am Dr. Francesco Prada. I'm a neurosurgeon at the Carlo Besta Neurologic Institute in Milan. I'm really happy to have on this panel a mixed array of experts ranging from clinicians to basic scientists. We have Delaney Fisher. She's a PhD student in Rich Price Lab at the UVA. We have Dr. Wei and also Dr. Chen from Changgung Memorial Hospital in Taiwan. We are two fellow neurosurgeons, Dr. Sanai, who is the chair of the neuro-oncology at the Barrow Neurosurgical Institute in Phoenix, and Kismet Ibrahim, a neurosurgeon in Dundee. And last but not least, we have Eleanor Stride, who is professor of biomedical engineering at the University of Oxford. So the idea that relies behind sonodynamic therapy is the combination of a non-toxic sensitizing chemical agent that has the property to selectively accumulate in the target tissue that we want to treat, is basically for solid lesions, and which is then sort of activated using a form of energy. The idea is not new, because fluorescein is one of those sensitizing agents, and actually in 1931 they were thinking about it. Actually, in this study they used, to treat breast cancer, they used radiation, so probably the effect they found was only due to radiation, not to the activation of fluorescent. However, this sort of sensitizer can be activated with light, for example. And currently they are employed to treat skin cancer or eye tumors or retinal tumors. The problem with the light is that, as you know, the penetration is very limited. So we can treat only superficial lesions. Sound, it has, of course, a much higher penetration. And with focused ultrasound, we can go deep into tissues, and we can reach the area where the sensitizer is accumulated. Both, the sensitizer per se doesn't have any effect. It exerts an effect when it is activated with ultrasound. There are many parameters and factors that need still to be understood. So in general, the ultrasound parameters used to perform sonodynamic therapy are in the low frequency range, usually with short duty cycle, and eventually there is a long exposure. The mechanism of action, there is a variety of mechanism of action under investigation. They're ranging from the pure motion induced by ultrasound to hyperthermia, or to the cavitation that probably it is thought to generate photons. Therefore, sonodynamic therapy is a sort of internal photodynamic therapy. And also the change of state and excitation of the sensitizer is able to contribute to the generation of reactive oxygen species, which then induce secondary apoptosis and then necrosis of the tumor. And also the effect of sonodynamic therapy on the plasma membrane probably is able to trigger an immune response. And this leads to exactly different by-effects: cytotoxic effects, anti-angiogenic mechanism, and immunological effects. This is a slide provided by Dr. Kismet Ibrahim in Dundee. They did some preclinical work, maybe we can talk about it later during the discussion, and they showed that there is production of reactive oxygen species, and apparently there is also a correlation with the location within the ultrasound beam. Hyperthermia was evaluated by the Sunnybrook group, by Kullervo-Heininen, and it seems that it doesn't play a major role into the tumor, into cell death. Anti-angiogenic mechanisms are also involved with, it has been shown by the group, with Dr. Zhang group, leading to microthrombosis within the tumor environment. And they also studied, and they showed that there is a modulation of the immune tumor environment with a higher expression of antigens from the lesion, and an activation, a corresponding activation of the immune system of T cells, which are usually silenced by tumors such as melanoma or glioblastoma. Professor Stride, she performed many studies regarding mechanism of action. She will provide probably an overview of the most intriguing systems. And also she provided this slide showing where she discussed the immune system induction from the sonodynamic therapy. Sensitizers, they are mainly porphyrin-based molecules or dyes, xanthan dyes. As I mentioned, they need to accumulate selectively in the target tissue, and per se, they do not exert any biological effect. We know from, for example, from our intraoperative data that we can collect routinely during surgery, that some of these sensitizers, such as 5-LA, which is a precursor of protoporphyrin 9, selectively accumulates in the tumor, and as you can see in this picture, here. The 5-LA, they accumulate selectively in the tumor. It highlights the tumor when it is visualized with a certain wavelength. And Professor Umemura showed clearly that 5-LA is, because it accumulates selectively in glioblastoma cells, when it is activated with a sound, is able to induce tumor regression. Another interesting sensitizer for brain tumors is fluorescein. Fluorescein has a different way of accumulating in the tumor, because 5-LA is metabolized, whereas fluorescein extravasate in the interstitial space where there is a BBB rupture. And it's less selective than 5-LA for glioma, for sure, but it has another appealing feature, which is the fact that it can highlight many different histotypes, such as meningioma, metastasis. So it's probably more versatile, and it is able to exert a sonodynamic effect, at least in preclinical model. And this has been also confirmed by Dr. Wang and Dr. Wei, which provided us with this, which are on the panel, and they provided us with this slide where they tested fluorescence and 5-LA in an intracranial glioma model. Sensitizer can also be applied to other kind of solid tumors. This is an example provided by Dr. Delaney Fisher, where they attempted to highlight and treat cavernous malformation, which are not a malignant tumor, but they're a vascular malformation, but they're usually deep-seated, difficult to resect. Therefore, it would be really highly desirable to treat them with sonodynamic therapy, and they tested various sensitizers to this end. Sonodynamic therapy appears to be a safe treatment modality. This is a safety study that we performed at University of Virginia, where we tested both 5LA and fluorescein in a porcine model. We tested this on the normal brain to show that there is no damage induced by sonodynamic therapy in the normal brain tissue. The sonodynamic therapy is not yet, is actually on the brink of getting used into, translating to clinical trial, into studies. There are a few reports regarding its use in breast cancer or in lung cancer. There are few reports. This is another report where it has been used in 3 cases in combination with photodynamic therapy. There is a huge interest towards the use of sonodynamic therapy in brain tumor cancer, like in glioblastoma especially, and the IPG, with 4 trials ongoing in the US. One is really advanced, the one conducted by Professor Sanai. And we are about to start a clinical trial, the first clinical trial in Europe at our institute in Milan. So now we are moving to the burning question, to the discussion. Sit here, more comfortable. So I think this is a really exciting new modality that it is under investigation. There are many aspects that has to be clarified and understood. And first of all, probably the most interesting is the mechanism of action that are elicited by sonodynamic therapy. I would like the panelists to provide some insight on their idea. Maybe we can start with Eleanor Stride, who did an extensive research in this field.
So I'm afraid my answer is going to be, I don't think we know yet.
Sorry, we can't hear you.
Oh.
No, now it's better.
It's working, okay. So I think we are still trying to understand exactly what is happening. I had a very talented student a few years ago who did some experiments, which to my amazement demonstrated that we do get light production, we do get sonoluminescence from microbubbles, even at the sorts of frequencies we use, so quite mild therapeutic frequencies, which we were not expecting. We still have not answered the question, do we have enough light to be activating the drug? We see absorption at the relevant wavelengths, but we're still trying to work that out. I've also had 2 fantastic students, Kritika and Sasha, working recently who have shown that intracellular uptake seems to be vital to facilitate sonodynamic therapy. So at the moment, I think we have a combination of different effects. I think we are facilitating better distribution of the drug. We are facilitating uptake of the drug, and then we may well also be seeing some sort of activation, potentially by sonoluminescence, but hopefully we'll solve that in the next few months.
Excellent. Maybe, Kismet, can you comment also on the production of the reactive oxygen species, relying on your preclinical studies?
So obviously I am hoping to bring sonodynamic therapy to the UK with the company called Sonosensitizers, and with their 2 commercial phase 2 trials that they've got planned. And as a scientist, I think I just wanted to take a step back. So I'm working with the biomedical engineers here in Dundee, Professor Zihong Huang, and we've got a lot of experience with photodynamic therapy. You know, we've run clinical trials of PDT for glioma before, and a lot of experience in skin. So I just went back a step and thought, well, it seems as though this is a photon-induced energy product. We're going to use high multispectral analysis to see exactly how much light is being produced, and it's not easy in a 2D and 3D neurosphere setup that we have in the biomedical engineering department. And I think I'm not quite answering your question here, but I think with us not knowing what are the ultimate parameters, I think we need to kind of work together with all the different people who are working on SDT in different areas around the world to try and just say, well, what makes sense? So we've tried different energies. We've tried 220 versus 650 kilohertz, and we know it's being produced by mitochondrial. The reactive oxygen species is in the mitochondria. We understand that it's definitely requires a combination of ALA and focused ultrasound, but what the exact pressure wave that's required is, I don't know. So we're all kind of working on Hinenen's work with his rat glioma model, where he showed that 0.75 kilopascals seems to work the best, and the longer the sonication, the better. But can patients tolerate so long in a machine? Which maybe Nada can answer us a bit better with his clinical experience. And yeah, I guess my question to the panel and maybe to the audience is, when I think you showed in that slide of mine that I had, when we measure the actual focused ultrasound beam that's going through, phantom tissue or liquid, or through our cells, there's a penumbra around it. So yes, we can mimic the 0.75 kilopascals that's been used in vivo and shown, almost cure of rat glioma over 3 sonications a week apart. But is that causing too much energy? Because energy is dependent on the volume that you're sonicating in. And maybe we're photo-bleaching the center and actually not causing that much cell kill, or causing a little bit of cell kill. Are we causing too much hypoxia? We need to measure hypoxia. And actually, is it the penumbra around it that's actually causing the cell kill? Some people overlap the treatment field, some people don't. So there's a lot of unknowns here. So I'm afraid I've come to this panel with more questions than answers, but that's why we're having a panel. So I might let one of the others hand over, but I hope that's helped a little bit in terms of what I'm thinking of and why we're doing the preclinical research at the same time as awaiting our UK approvals to run the 2 clinical trials, hopefully next year. Thank you.
Okay, thank you, Kismet. Yeah, you introduced already one of the other topic that we'd like to discuss, which are the parameters. But before discussing parameters, since cavitation is one of the mechanism of action, or probably the primum movens of all mechanism of action, I have a question for Dr. Sanai. Since you're conducting, it's actually a curiosity, since you're conducting clinical trial and you're using a system which has cavitation detection, did you use it during the sonication, during the treatment? And if yes, did you measure any bubble activity?
Yeah, thanks, Francesco. Yeah, so we are using the InsightTech system in conjunction with the Sonalisense drug. We do look for cavitation. We have 3 energy levels so far that we've tested: 200, 400, 800. We haven't seen cavitation in any of them yet. We auto shut off when we see cavitation in our trial. So far I haven't seen that.
Okay, well, thank you very much. So, Kismet introduced already the issue, the question regarding the parameters that we need to use. Here we have both preclinical researchers and clinical users. So, maybe Delaney, can you tell us about the parameters that you're using when you're performing sonodynamic therapy? Thank you.
So I'm applying this to a novel therapy or a novel application, which is cerebral cavernous malformation. So it's still an uncharted space for us. So we are still working on FUS parameters as well as sonosensitizers that will be ideal for this disease. So we're still in an early phase. Right now we're looking at lower end intensities of sonodynamic therapy. So our first step is looking at 2 watts per centimeter squared intensity. And we will probably work our way up to higher intensities as we go. Since this is a hemorrhagic vascular malformation, we are worried about potential poor outcomes if we go too high of an intensity with sonodynamic therapy. So for us, we're working on the lower end and working our way up, which might not be the same application or the same approach that you may use in a solid tumor.
And Eleanor, can you add something for example, for pancreatic cancer?
Yes, so I mean, we've tried to look at whether we can find an optimal set of parameters. So certainly, interestingly, we don't see any effect in vitro or in animal models without cavitation. So our controls where we've just used drug and ultrasound, we don't actually see any therapeutic effect, so that's an interesting question to look further into. We've certainly found that lower frequencies seem to produce more cavitation and more of an effect, so 0.5 megahertz seems to be a good compromise between depth, the ability to still focus, and easily generate cavitation. As you'd expect, with amplitude, we see an increase in effect with increasing amplitude, up to the point, though, where we think we are destroying the bubbles too quickly. Because we also see there seems to be an optimal duty cycle and pulse duration, and we suspect that we need to sustain cavitation for a certain duration of time to get the effect. And therefore, if we go too high in amplitude or too short in our pulses, that we're losing bubbles too quickly. But yeah, so that's the findings that we've, and it seems pretty consistent between in vitro and in vivo. I think the other interesting thing we found is there is not a perfect correlation to reactive oxygen species generation that we found, although I should caveat that by saying we found it extremely difficult to find a very reliable reactive oxygen species sensor, and obviously depending on the drug, there may be different species generated. So again, I apologize, I'm producing more problems as well, but I think all these are important to discuss.
Okay, thank you very much. And then there, since you are conducting a clinical trial in a glioblastoma patient, can you provide us with some insight about the parameters that you're using?
Yeah, sure. So our phase 01 trial is a protocol for recurrent high-grade glioma patients. And in each patient, half the tumor is targeted with sonodynamic therapy, approximately 4 hours after receiving the IV drug, and the other half of the tumor is left as an internal control. Then the patient goes on to resection. In the first phase of the study, they go on to resection 4 days after the treatment, and the tumor is removed en bloc, and then the treatment component of the tumor is compared to the control. The drug dose in the first phase of the study is 10 mg per kg of the Sonalisence IV formulation ALA. The energy levels range from 200 to 400 to 800 at the 3 dose levels that we've tested so far. At each dose level, it's a 4% duty cycle with 100-second duration, and then the wattage is increased from 50 to 100 to 200. We've now completed those 3 energy levels, and we're moving on to looking at longer intervals of time between the treatment and the operation. At those energy levels, we've used various pharmacokinetic techniques to measure reactive oxygen species as a surrogate for redox reactions. And we've seen statistically different levels of that in treatment versus control. We've also seen statistically different levels of cell death in treatment versus control. We have not seen any radiographic evidence of tumor effects remotely similar to what's seen in preclinical models, although it may be that we have the wrong parameters. It may be that you're not going to see those 4 days after treatment. So our next interval of time will be somewhere in the vicinity of 7 to 10 days after treatment. And we're hoping that the longer interval, while it may not give us more visibility into the redox side of things, because those are going to be very ultra early events, will hopefully give us a better sense of the level of cell death associated with treatment.
Well, thank you very much. Very, very interesting. And since you mentioned the sonosensitizers, which is a different formulation of the 5LA that is usually used to visualize, to highlight tumors during surgery, do you think that this makes a difference? And then afterwards, I would like to ask to the panelists, if there are other sensitizers and how you look into new sensitizers. So Nader, can you comment on the sonosensitizers and then we move on?
Yeah, we've done plasma pharmacokinetics on 5-ALA and protoporphyrin 9 in response to that drug. They're effectively identical to the oral formulation. So from our perspective, it's probably equivalent. We don't really see much of a difference one way or the other compared to what we would expect with glialin.
Thank you. Kismet, since this is a neurosurgeon-oriented question, do you have any comment on that?
Yeah, I know that sonosensitizers state that there's less hepatotoxicity with their intravenous formulation compared to the oral one, but I mean, I've been using the oral one for over 10 years now, because remember in the UK we've used ALA for a long, long time, and to be honest, I don't think I've ever seen any hepatotoxicity with the oral one either, so I think they're both safe drugs, but there are other things we've used photoferrin in experimental studies in Dundee before for glioma. Remember that photoferrin does cause more thrombosis, and it's only, at least in the UK, licensed for head and neck use, so it's not licensed for use in brain anymore. It was only experimentally, and similarly with Vigidine, you mentioned before, you can use photosensitizers for optical tumours. That also is more likely to cause thrombosis. So I think for practical reasons, we should be going with oral ALA like you're using in Milan, and intravenous ALA like Nada's using in the USA, and I plan to use here in the UK next year. Thanks.
Yeah, that makes sense. So in our study in Milan, we're going to use 5LA, the commercially available modality, the drug that we use for intraoperative visualization. We are also thinking of using fluorescent. As I mentioned, this is a sensitizer that can be uptaken by other brain tumors. So 5LA is only limited to glioblastoma. Fluorescent can also be used to descend. And Dr. Huang, since you perform also some preclinical studies, can you comment on the differences between the use of 5LA and fluorescent in glioma?
Oh yes, here we use fluorescent in the subcutaneous model, and we also use 5LA in animal models in the same model. We found these two types of sonosensitizer, the reaction is almost the same, but I'm sorry, we didn't use fluorescent in our animal brain tumor model, so I cannot answer the question about in the brain tumor, how is the effect between fluorescent and the 5LA. But in our work in animal model brain tumor, 5LA works very well, and we use the clinical use glialin for the oral administration. And I think maybe next time we can try to use fluorescent in the animal model for brain tumor. We can try it. Thank you.
Oh, that's great. And following on this quest for sensitizers, Delaney, you did some very interesting work trying to find a new sensitizer for cavernomas. Can you comment on that?
Yeah, so again, since cavernous malformation has not really been used for sonodynamic therapy yet, we had some initial work to do to figure out what sonosensitizers would be appropriate for this disease. Like many people, I think we started with 5-ALA, given that it's one of the more popular sensitizing agents in the field. But as we, and I think Francesco has seen as well, that 5-ALA is not particularly the best binding to cavernous, or the mutated endothelial cells in the cavernomas. We have pivoted now, and there was a paper that came out a couple of years ago, or recently, by Kobetz and colleagues that found that tazoluristide, which is a chlorotoxin peptide with an infrared dye conjugated to it, actually incidentally bound to cavernomas in patients. So that has given us an outlook to investigate tazoluristide in our murine models. We've also looked at fluorescein as well, and given that it does accumulate in areas where there's leakiness in the vasculature, it does also seem to accumulate as well in cavernomas. So going forward, we're looking into tazoluristide as well as fluorescein, but not so much 5-OLA.
Oh, thank you very much. So moving towards targeting lesion, the lesion that we want to treat. Dr. Chen, can you, Dr. Chen is working with, is in Taiwan and will work with Navifast and is working with Navifast. Can you tell us how you envisage to use your system to perform transcranial sonodynamic therapy, and so whether it would be needed to target only the lesion only, to target the periphery, or the whole organ. So,
thank you for the question. In the previous talk, we mentioned that we use the fast BBBO strategy to treat recurrent glioblastoma, and also the 5-ALA is already a fluorescein guided during the surgery. So I think the sonodynamic point of view is a attractive method for us to treat recurrent tumors. And for our system, without the microbubbles, we can also deliver targeted regions along resecting margin. The main problem might be that we could not now check the actual effect of the sonodynamic function produced by the 5-ALA currently. And we are planning to do clinical trials regarding the sonodynamic therapy maybe next year. And before that, we should sort out how to manage the timeline and the treatment strategy just to prove that it is working.
Okay, great. And Kismet, since you earlier mentioned the interaction of the ultrasound beam with the sensitizers, and you were discussing the possibility that different power within the acoustic wave elicit a different amount of by-effects. So you were talking about this sort of penumbra concept. Can you comment on that?
I think you put me on the spot. I think
I like that.
I pay $10 to anyone who can answer that question. I think more preclinical work is required, especially with the Navifast system, to see, are they delivering enough energy over a whole hemisphere, for example, to allow SDG to work. We know from Nada's initial work that he's got this beautiful intra-patient control where the untreated half doesn't have the reactive oxygen species or cell kill seen in the treated half. So we know it's having an effect. But my question is, we don't know which part of the beam is having the effect. With the Insight Tech system that I'm planning to use and that you're planning to use, and they're using in the Barrow, the energy is delivered. It's almost like cylinders, because obviously there's 1,024 arrays, of which about 800 or 900 are used per sonication. So the question is it the center of that thing that's causing cell kill? Is it the edge of it where maybe you're not getting quite as much energy? Yeah, I have concerns about treating a large field with a non-focused beam. I think focusing is the way forward. Also, it's very important for when we're looking at areas of recurrent tumor that may be too deep for a neurosurgeon to get to safely, that we might say, well, look, let's try this. And I think the key thing that we haven't quite mentioned is that this is repeatable. Remember, I'm sure as neurosurgeons, all of us have had a patient where the operation's cancelled and you just give them the ALA again the next day and they're perfectly fine, So we have given ALA to people repeatedly before, and what about all the porphyrias where people have huge doses of porphyrin in their body and it doesn't cause any neurotoxicity? So I just thought I'd just mention that at the same time. So sorry, I haven't answered your question again. That seems to be my little forte here, but I think the proof is going to be in the pudding. What we're planning to do with our animal studies in Dundee is trying to you can localize where the beam is in the animal and then cut your histological samples along that same orientation to see if you can see whether there's more cell kill at the penumbra compared to the center. But that's planned for next year. But that's something that we look at in the preclinical study to see penumbra versus central area. But I think the other thing is just to vary the dose in preclinical studies. Thanks.
Thank you very much. And Nader, from a practical standpoint, when you are planning sonodynamic therapy in your cases, how do you practical and what areas do you target within the tumor and the surrounding brain? How do you deal with that?
Well, I think for those who use the device, you know that the lower you go, the harder it is to target. So we haven't tried to target anything in the posterior fossa yet. There's a pediatric DIPG study that's treated the first patient within the pons, but the geometry of a child's pons is not the same as the geometry of an adult's cerebrum. So I don't know exactly what the lower limits are yet of what we can target. I think for us, tumor volume has been a significant parameter to consider because of the duration of treatment that's required. You know, these are patients that, at least in the framed version of the device, which we currently have, are not going to tolerate being in the device for several hours on end unless they're under anesthesia. So I think tumor volume has been something we've been careful about. And then at the same time, you know, with the current limitations on the targeting package and software for the device, the symmetry of the lesion also can lend itself to more easy treatment, and significantly asymmetrical lesions can be harder to target in a single session.
Oh, great, thank you. And Eleanor, do you have experience with other solid tumors? Because we kept the discussion with 4 neurosurgeons on the panel, a little bit glioma centered, but yes, can you share your experience with other solid tumors?
Absolutely. So this is collaboration with my colleagues in Northern Ireland, but we've looked at breast, prostate, pancreas. These are obviously all in animals, but different strains. It does make a difference. So not unexpectedly, the vascularity of the tumor is very important, probably because it is affecting reactive oxygen species production, if that is the mechanism, or certainly just the sensitivity of the cells, but also very simply the distribution of the drug that you're able to get in. So we found a very clear correlation to tumor vascularity. So I think in treatment planning where you do have very, very heterogeneous vascularity, that's going to be a very important consideration. But it's in terms of the efficacy, it seems to be very good across multiple different tumor types, which is extremely exciting.
Okay. Oh, we also have a question from the audience. So to you, Eleanor, again. They're asking, Frederick Padilla is asking about the cavitation component of the sonodynamic therapy treatment with microbubble. Do you think it's an enhancement of drug penetration or distribution in the tumor, or the activation of the drug?
Honest answer, I don't know. It could be all of the above. Certainly we do see enhanced penetration, and we certainly see that some of these drugs are toxic when they're intracellular, even in the absence of any reactive oxygen species production. So I don't think we can discount that as a relevant mechanism. In terms of the utility clinically, it doesn't matter. We have a difference between intra and extracellular toxicity, so we're still getting the same benefit, but mechanistically, that's probably contributing. As I say, at the moment, we definitely have light production. We definitely have a toxic effect, and we definitely have a reduction in the absorbance at the right wavelength. I think we are not at the point where we can definitely join the dots to say we have activation by light, but I hope we'll know that soon. But yeah, my gut feeling at the moment is it's a combination of all of these effects that's helping. Although I can't currently explain why NADA's been successful in the absence of cavitation. So there's another mystery for us to solve there.
Okay, thank you. With this question, we jump to the last point, which also using microbubble to enhance sonodynamic therapy per se, or using microbubble loaded with drugs or oxygen. You did some very interesting experiment on that.
We did. So we definitely found that conjugating the drug to the bubble seems to help dramatically. We reduce the dose at which we see a similar therapeutic effect. That's not massively surprising, to be honest. There's work from 20 years ago showing tethering DNA to bubbles helps with the delivery. So I think that is a very logical finding. And similarly, providing a reservoir of oxygen inside the bubble also seems to promote the effect. There is again a trade-off, so oxygen bubbles are far less stable than perfluorocarbon bubbles, so there's a trade-off in terms of circulation time and stability versus actually enhancing the drug effect. So we've actually ended up with a mixture of oxygen and perfluorocarbon to get the best effect there. But yeah, it certainly seems to potentiate the drug.
Oh, thank you. And a question for Dr. Wang and Dr. Chen also. Considering that you showed very nice data on the use of microbubble for blood-brain barrier opening, are you thinking of combining microbubble and sonodynamic therapy eventually in a clinical trial with the Navifast system in the future? Dr. Huang?
Oh, yes. In an animal study, we didn't use microbubble, but we can see the effect is very good. So maybe combine with microbubble, or microbubble combine with some other drug on it, or combine with some more oxygen on it. I think it would be better.
Okay, then we can jump to the last question, which is how do we measure the efficacy of and the outcome of sonodynamic therapy? So maybe, Delaney, you can start on that.
So this has really been one of the questions that I've been wondering. So most of my experience is in the blood-brain barrier opening space, and obviously in that realm we have the ability to use gadolinium contrast enhancement following BBB opening. So right now I don't know if there are clear answers to this question. It's something we're thinking about at the University of Virginia. We're thinking about ways to incorporate PET with this, but I can't speak too much about that right now. Okay. But I do think it's something that all of us in this field should be thinking about is how do we know both the effectiveness of sonodynamic therapy acutely following treatment, as well as what should we be measuring for the longer term outcomes. And of course, that'll be different for the different diseases that we're treating here. Are we hoping to get an immune response? Are we hoping to get cell death? In my case, are we hoping to stabilize lesions? I'd like to turn it over to the rest of the panelists if they have any thoughts as well on this.
Nader, how are you measuring the effectiveness of sonodynamic therapy? Because we have seen in the BBB panel that you can perform various MRI sequences to see at least if the BBB opening was achieved. I don't want to say that I don't want to comment about the drug, but with sonodynamic therapy, we really cannot measure, at least what we did in our preclinical study, an active phenomenon occurring during sonication. Is there any feeling or anything that you've measured to obtain this information during your clinical trial?
Well, I mean, I didn't listen to the BBB session, but my feeling is we just have to be as specific as possible when we're performing readouts of these various interventions. For BBB work, for example, looking at gadolinium invasion, things like that, is not probably the right answer. It needs to be, the question needs to be asked in the context of unbound drug concentrations within conventionally non-enhancing tumor tissue, that would be a specific readout that would convince me that we're achieving the right result. With sonodynamic therapy, I think the specific readout has to be cell death. And frankly, if we're going to achieve clinically relevant effects with the strategy, it has to be cell death in conjunction with some radiographic signal that shows you're reaching a clinical level of cellular impact. I mentioned that we see microscopically a significant difference in cell death, but I don't think any of us are under the illusion that the magnitude of that effect is going to reach clinical relevance with the current approach. So I think that it's going to be important to ask these questions in human tissue. Obviously, the preclinical models are posing for us some really important concepts, but at the end of the day, there's obviously a wide gap between preclinical and clinical data in neuro-oncology in general, and so we have to ask and answer these questions in the patients themselves. I think none of us will feel that we've concluded this round of interrogation to our satisfaction until we see really significant levels of SDT-induced cell death and hopefully radiographic changes that are consistent with that.
Eleanor, do you have anything to add to this in terms of monitoring the efficacy of SDT?
Yeah, no, I would completely agree with both, that I think the outcomes need to be defined for the specific tumor or other condition that we're trying to treat. And yeah, we have got to be absolutely certain of how it's going to work in human tissue, because it doesn't need saying, but animal models only tell you so much. I think the promising thing with SDT is it seems to be fairly agnostic to the tumor type, which is very encouraging for translation. But yeah, the proof of the pudding is when we see this actually working clinically.
Thank you very much. So we've gone through all the burning questions. Is there any? Oh, sorry. I was looking the other way. Yeah.
Thanks, Francesco.
Other questions, please.
Yeah. So there's immunology in here somewhere, right? So I'm intrigued as to whether the type of cell death that is occurring is consistent across tumor types, and when you change the sonosensitizer, does that change the type of apoptosis? So are we looking at efferocytosis? Are we looking at paroptosis? And does that have sequelae in terms of the quality of the innate immune response, the myeloid response that occurs after treatment?
I have experience with only two types of sensitizers in glioma, and we haven't observed a huge difference with the two sensitizers, although we didn't explore a wide range of parameters. In terms of the immune response, I have to say that we performed an in vivo study in mice, and we observed a remarkable response with the ultrasound, in the ultrasound group only. It was enhanced in the sonodynamic therapy group, of course, but also was induced by ultrasound only with a huge impact on the microenvironment. So that was our take. I don't know if Dr. Huang or Dr. Strai would like to add something. Dr. Huang?
No, I was just going to say that's completely consistent with our findings as well, that there is a mechanical effect, or possibly a thermomechanical effect of the ultrasound alone that is pretty significant.
So I find it quite fascinating that it's not being perturbed by the addition of the sonodynamic therapy, that's not layering into the sort of quality of the type of cell death. And then I think it's going to be really important going forward, not just to look at the myeloid cells, but how the fibroblasts are responding in that in terms of the cytokines they're producing, because that could alter the milieu quite phenomenally. And I think getting the human tissues to understand how the myeloid cells are responding in that space is going to be really, really important.
Okay, thank you. Are there other questions? Okay, thank you very much, the panelists. Thank you for your attention, and we can enjoy lunch, I guess, now. Thank you.
Thank you. Yeah, I think we're all getting a little bit hungry. So we will have a 90-minute lunch break. Things will resume at 1:45. We'll start with a panel on chronic pain, followed by veterinary panel. I do want to make you aware of a Cranion users lunch that's happening now in Brookside A and B, which is downstairs, and there's food available outside the room. If you don't know what Cranion is, it is an open source visual computing platform for modeling transcranial ultrasound procedures. So please join that session if you're interested. See you at 1:45.